So hello friends. So today I'll be talking on this new drug, Cotrimoxazole. So it's not a new drug, but currently it is available as injection. So as you know, friends, so this is quite a old drug. Before only oral formulation was available. So of late there has been an IV formulation. So I would call this as a more as a repurposed drug in ICU, and it has a unique sort of a utility in intensive care. So the reason I'm talking about this is in the light of this PCP multi study that came in 2024 in intensive care medicine, and discussion on these drugs becomes even more pertinent in the light of this particular study that came. So I'll just take you through the overview of this cotrimoxazole, which has a renewed utility in intensive care unit. So as most of you know, friends, cotrimoxazole is a combination of sulfamethoxazole and trimethoprim, and they're always available in combination. Why combination? Because individually sulfamethoxazole or trimethoprim by itself they are bacteriostatic, but when they get combined they become bactericidal, and almost always the ratio of sulfamethoxazole to trimethoprim will be 5:1. So if there is 800 mg sulfamethoxazole, so there'll be 1/5 of trimethoprim, that will be 160, that will be present in the tablet, and so is the case in the injectable format. So together, when you combine these two drugs together, it becomes bactericidal. So that is the beauty of this particular drug. And how does it act? It acts by inhibiting folic acid synthesis within the bacteria. So for all the listeners, none of the mammals, like we're all mammals, we don't produce folic acid. So folic acid is distinctly produced by the organism. So we get folate by ingestion of folate from the food items. So bacteria produce their folate. So this particular drug acts by inhibiting the folic acid synthesis within the bacteria, and it acts on the specific pathway that is involved in synthesis of folic acid in the bacteria. So the pathway is, there is para-aminobenzoic acid which combines with pteridine in bacteria, and in the presence of pteridine synthetase, it forms dihydropteroic acid. So sulfamethoxazole acts at this enzymatic level and prevents this particular step in the pathway of folic acid production. And dihydropteroic acid, in the presence of dihydrofolate synthetase, dihydrofolic acid is formed. And this, in the presence of dihydrofolate reductase, is converted to folic acid, tetrahydrofolic acid. Trimethoprim acts at this step, acts at the dihydrofolate reductase step, and prevents the formation of folic acid. And folic acid is produces its metabolites like thymidine, purine, and methionine. So this is the folic acid pathway that happens in many of the organisms, and sulfamethoxazole acts in certain pathways of this and prevents the formation of folic acid. And why we are not using cotrimoxazole now? Because sulfamethoxazole is a very old drug. It was first invented in 1930, and this combination came into existence in 1950. So it is an old drug, and because of the increasing resistance to cotrimoxazole, this drug had been stopped and it has not been very popular, and only oral formulation was available. And the resistance is mainly because the bugs are very clever. So once they get exposed to this drug, they start producing increased amounts of para-aminobenzoic acid, and the drug you give may not necessarily be enough to do all this to obstruct this conversion of PABA, increased amount of PABA to folic acid. So increased production of PABA by the organisms confers resistance, and sometimes there can be alteration in this dihydroteroic acid, which confers resistance to cotrimoxazole. So these are some of the resistant mechanisms that bugs evolve to cause resistance to this bug. And some of the bugs that have developed resistance to cotrimoxazole are meningococcus, gonococcus, even streptococcus. This was a good drug earlier on used for these organisms, especially for all the STDs, they were using it. Because of the increasing resistance, that utility has sort of come down. And Shigella also has developed resistance. So what is the beauty of this drug? Why are we now talking on cotrimoxazole in this era? Because as far as I can recall, this is the only drug which has spectrum on all the 4 different types of organisms: gram-negative, gram-positive, fungi, and protozoa. So it has effectiveness against all these 4 dimensions of organisms, which I don't think any other drug has this sort of a spectrum. And amongst these four, it's a drug of choice for one fungi, which we'll be talking about in a little bit detail, which is Pneumocystis carinii or Pneumocystic Jerovici. And it's a drug of choice. So for GPCs, it has an excellent activity against MRSA. I'm just putting how the MRSA looks morphologically. So it is effective against MRSA. And if you look at the literature, there are multiple studies looking at the effectiveness of this drug in MRSA. So it has still retained good efficacy against MRSA. And actinomycetes, this is also a drug which is very useful in actinomycetes and listeria. We do often see listeria even in our ICU now. Recently, we had a patient with listeria meningitis. So it's not an uncommon elderly immunocompromised listeria does happen, and this is a GPC for which cotrimoxazole can be effective, or ampicillin, high dose ampicillin or amoxicillin can be given. So gram negative, it is effective against chlamydia and few other gram negative, which we'll be talking on. And protozoa, it is effective against toxoplasma. Toxoplasma is seen in HIV patients, especially when they're not on heart therapy. So it is effective against protozoa toxoplasma. And fungi, in fact, there's no other drug for Pneumocystis jerovaci. And cotrimoxazole is a drug of choice for Pneumocystis carinii or Pneumocystis jerovaci. So, and this is a drug of choice. If this drug for whatever reason is not tolerated, then you have to look at either only trimethoprim in isolation, or you have to look at atavaquine and so on and so forth. But the drug of choice remains cotrimoxazole. So this is the beauty of this. So it has effectiveness against gram positive, gram negative, protozoa, and fungi. So when we look at pharmacokinetics, it is absorbed orally. Obviously, we are talking about IV formulation, and half-life is around 10 hours. And this drug is metabolized in the liver by acetylation. So this study by Canada has shown that although this drug gets metabolized by acetylation in liver, so liver dysfunction not necessarily will affect the whole acetylation process. And it undergoes acetylation and forms some microcrystals. So that is another issue with this drug. So liver dysfunction has no role on the metabolism, but there can be accumulation of these microcrystals, and it gets excreted in the kidney. And even in the kidney, it causes microcrystals. There are crystal formation leading to acute kidney injury or kidney damage. So this is one of the side effects that one should bear in mind. And since in ICU, many of them will have acute kidney injury on dialysis, so this drug is dialysable. So the dialysis filters out this particular drug. And with regards to teratogenicity, sulfamethoxazole enters through the placental circulation, so it is not to be used in pregnancy or in or lactating mothers. And trimethoprim can enter the blood-brain barrier, can cross the blood-brain barrier. So it can be useful when you are treating patients with meningitis, so on and so forth. Because listeria meningitis, this has a good blood-brain barrier penetration, and it may be of benefit in these cases. So this is about, in brief, about pharmacokinetics. So we'll talk about the type of bugs that we see in ICU and where this could be utilized. So Stenotrophomonas maltophilia, I'm sure all the listeners here would be aware of this drug which causes problem in ICU. And this typically tends to happen in a deconditioned patients after having stayed in ICU for a long time on tracheostomy with multi-organ. In the recovery phase, we do often see Stenotrophomonas maltophilia, and cotrimoxazole can be a drug of choice in these sort of patients. And this is the morphology, how the organisms look. It's a gram-negative bacillus. And typically, this infection occurs in immunosuppressed individuals. And there are studies to show its effectiveness. When I talk about studies in cotrimoxazole, most of it is confined to large case series or case reports. Obviously, you cannot have randomized controlled trials. So this is a case series from Israel where they've showed cotrimoxazole was very effective against meningitis caused by Stenotrophomonas maltophilia. And this was a study by US where cotrimoxazole was found to be effective against Stenotrophomonas causing bacteremia. And this was a study from Saudi Arabia where they showed cotrimoxazole being very effective in treating Stenotrophomonas causing endocarditis. So these are some of the situations where cotrimoxazole has been effective in facilitating good curative care. And even in hematological malignancies, cotrimoxazole was found to have good cure rates. So Stenotrophomonas, so there is reasonable body of evidence that it was effective in those clinical conditions. And Burkholderia cepacia, this is also a gram-negative bacillus, and we do see this again in a deconditioned patients in ICU. And I'm sure many of you would have seen this in your ICU setting. And this typically occurs in patients where there is already a lung damage. So patients having any cystic fibrosis or cavitations. So this particular bug tends to affect. And this Burkholderia cepacia has an affinity to cause infections in patients with granulomatous conditions, like if they have had tuberculosis or Wegener's granulomatosis. So wherever there is granulomatous conditions or lung damage due to cystic fibrosis, so on and so forth, Burkholderia cepacia. So these granulomatous conditions where Burkholderia cepacia can occur. And these are the studies, one from Japan and from US, where they have shown cotrimoxazole has good sensitivity against Burkholderia and has had a good clinical response. And Burkholderia pseudomulli is something that we see in more of Southeast Asian. It causes melioidosis, and this is, I'm sure, MCQ questions people would ask. So it is a causes melioidosis, and this is the morphology of the organisms, how it looks, and this can cause sepsis. So melioidosis can cause severe sepsis, septic shock, multi-organ. It can cause pneumonia, and it can cause skin infections, and it can cause intra-abdominal infections. These are the typical sites of melioidosis that it can cause infections. And the typical drug of choice, I'm sure most listeners would know, it's ceftazidime. So, but these are the studies. So this is a study from Australia and Thailand where they compared ceftazidime combined with cotrimoxazole versus cotrimoxazole alone. So they compared these two and they found there's no difference, which means to say cotrimoxazole is fairly potent against Burkholderia pseudomulli and it can be effective in treating this condition. But traditionally, drug of choice has been ceftazidime. So cotrimoxazole can be used as an adjunct in severe sort of these cases, and it has shown good potency, or even as a singular agent, it has shown to have good potency. Now coming to Listeria monocytogenes, as I said, these are the bugs, gram-positive cocci. It tends to cause meningitis in especially elderly patients, immunosuppressed. In fact, we have had an article published in an elderly patients with Listeria meningitis, and recently we had one elderly gentleman coming with Listeria monocytogenes meningitis. And this is the morphology of the organisms. It's a gram-positive cocci. Typically, it causes meningitis, but it can cause sepsis with bacteremia. And the drug of choice is usually cotrimoxazole in combination with either gentamicin, amoxicillin, or with rifampicin. And so this was a study from Spain where they have used in solid organ tumors. And they have shown cotrimoxazole prophylaxis had a good significant protective element in this particular study. And this was a study from France where against Listeria, they compared cotrimoxazole with ampicillin versus gentamicin with ampicillin. And they found that cotrimoxazole with ampicillin had more superior effect in attaining good curative rates as opposed to gentamicin with ampicillin. So we do see Listeria. So for all the listeners, bear in mind, you see Listeria meningitis, you can use cotrimoxazole injection with ampicillin because the trimethoprim has a good blood-brain barrier penetration and it may be effective, and so is ampicillin. So this combination may be better if you are contemplating the combination regimes for Listeria. So then we'll just move on to MRSA. As I said, if you dig into the literature, a lot of literature on cotrimoxazole is in MRSA. And as we know, MRSA infections, the mortality can be 5 times higher. And MRSA in ICU typically can come with pneumonia or MRSA endocarditis. So this was just an epidemiological study from Israel where they showed the cotrimoxazole sensitivity from 1988 has significantly increased from 31% to 92%, which means because of less usage of cotrimoxazole, the resistance pattern has come down, and in fact, the sensitivity has gone up to 92% in 1997. So when you look into the literature, there are 7 randomized controlled trials, 7 retrospective studies, and 2 prospective studies that are done until date for MRSA. And there is this one randomized controlled trial done by Japan where they showed cotrimoxazole was effective in preventing pneumonia in the burns patient. And these are the RCTs from USA, 2 randomized controlled trials where they've shown that cotrimoxazole prevents the recurrence of abscesses formation, because MRSA, I'm sure most of you know, are notorious in causing multiple abscesses. And there are 3 randomized controlled trials done in skin and soft tissue infections and osteomyelitis. And these are the 3 RCTs done by Australia, Spain, and USA, where they've shown cotrimoxazole having good efficacy, which was similar to doxycycline and other agents. And there was one randomized control trial which compared cotrimoxazole versus vancomycin in MRSA sepsis, MRSA bacteremia. This was from USA, and they found that cotrimoxazole had a similar efficacy when compared to vancomycin. So, which means to say there is a overwhelming usage of vancomycin of late, I'm sure, maybe ticoplanin and maybe linezolid. So keep in mind this old drug, repurposed drug, which still retains good sensitivity to MRSA. And if you get MRSA, which is sensitive to cotrimoxazole, you could possibly embark on its usage because all these studies have shown good efficacy and similar sort of an outcomes. And even there are retrospective and prospective studies which have shown good clinical response in cellulitis, osteomyelitis, or prosthesis infections, and even in otitis media. So they have shown good sort of a clinical response in all these gram-positive infections. In addition to this, the cotrimoxazole has effective on the mycobacteria. So that typically we see some oncology cases where ATT may have been put in empirically. So I think if you're treating as a broad spectrum cover, this also has an effectiveness against certain mycobacteria. I'm not telling tuberculosis because tuberculosis we have different regime, but mycobacterium, avium intracellular, which all tends to occur in immunosuppressed patients, especially HIV. So it is shown to be very effective. So there are case reports and case series which have shown good effectiveness against non-TB mycobacteria like Mycobacterium fortuitum, marinum, and it is shown in HIV patients, cotrimoxazole prevents Mycobacterium avium intracellular, which is a problem in these immunosuppressed patients. So this is about its effectiveness in certain organisms we see commonly in ICU. Now coming to the question in discussion, Pneumocystis jirovecii, and this is the morphology of this fungi, and the only drug currently available and which can be used effectively is cotrimoxazole. And until now, we had only tablets. Now we have this injection available, and it is a drug of choice. This is the first drug of choice. And the dosage is you have to look at trimethoprim as a dose. It should be 15 to 20 milligram per kg per day. You give it in 3 to 4 divided doses. And one has to bear in mind when you are giving this cotrimoxazole, it is fraught with certain side effects, and every intensivist should bear in mind the side effects. So the skin rash, that because it's a sulfur drug, any sulfur drug tends to have skin rash, or they can lead to erythema multiforme, Stevens-Johnson syndrome, and even toxic epidermolysis necrosis. So skin rash has been the commonest sort of a side effects in cotrimoxazole. They can cause low-grade fever. They can cause cytopenias, leukopenia, pancytopenia, bone marrow suppression. All these can occur due to cotrimoxazole. And one important side effects which every intensivist should bear in mind, especially when you're using injectable cotrimoxazole, is hyperkalemia. Because if you do not monitor potassium and you are giving high dose of cotrimoxazole, very often you may have hyperkalemia, and that can cause life-threatening problems. So please keep an eye on checking on monitoring the potassium levels, because it gets excreted in the kidney and causes microcrystals. It can cause acute kidney injury. It can cause hemolysis and LDH. That's why we look at LDH as a surrogate marker. And there can be transaminitis. So AST, ALT levels can go up. And as I said, metabolism happens by acetylation in the liver. So some transaminitis happens. So these are common side effects. But two side effects you need to bear in mind is mainly the skin reaction and hyperkalemia. And most of these reactions are idiosyncratic. They're not dose dependent. So you give first dose, they can develop these sort of reactions. So now just embarking as to why we are talking on cotrimoxazole is because we just very briefly, I'll summarize this particular study we discussed recently. It's a very good observational study, large observational study on Pneumocystis jirovecii pneumonia, PCP multi-study done in France. If you see the title, it's Pneumocystis pneumonia in intensive care. So this is the largest study that one could embark upon to look at the mortality and outcome of PCP infections. And this came in this month, 2024, September. This was released from France. So this was a multicentric prospective observational study done across 49 ICUs in France to evaluate severe Pneumocystis jirovecii pneumonia and to look at it's an observational study looking at the patterns, how the PJP infections are happening right now in intensive care. So looking at the severity, looking at the clinical spectrum, and looking at the outcome of these patients affected with pneumocystic cerevisiae pneumonia. And here they have looked at the role of antibiotics and role of steroids and what impact it had on the mortality. Basically, they looked at the usage of cotrimoxazole and adjunctive steroids and its effect on the mortality. And this study was conducted between September 2020 to August 2022. So they took 158 patients with pneumocystic cerevisiae pneumonia in 49 ICUs in France. And as you see, 94.9% of the patients presented with acute respiratory failure. And antibiotic, this is important, friends. I want to emphasize, these were all immunosuppressed patients or HIV patients. These patients, antibiotic prophylaxis was given in only 12% of the patients. And so that is a thing to bear in mind, that one should have a high index of suspicion as to who are the patients who are at a risk of developing PJP infections and put them on prophylaxis to prevent death. And when they looked at ICU mortality with PJP infections, it was 31.6%, and hospital mortality was 35.4%, and 6 months mortality was 40. So the mortality in PJP infections in ICU can be up to 35 to 40% is the mortality. And they don't come and say, I have PJP infection. So clinicians should have a high index of suspicion to evaluate, determine, and treat them. Otherwise, these patients can die. So just for all our trainees, I need to talk on this statistical tool they used. They used the time to event, propensity score, inverse probability, treatment weightage. So this is the statistical tool that they used in this study. So just to very briefly talk about this statistical tool. So it is a time to event. As the name suggests, it's the time taken for the event to happen, and inverse probability, therapy weightage. So this is a statistical sort of a tool that you use to compare two groups, group 1 and group 2, and looking at outcomes at various timelines. That's why we call it time to event. So we compare two groups and look at the events that are occurring at various timelines. And propensity score is where different treatments are given in these two groups, and it adjusts the comparison and removes the confounders to try to distill out the pure treatment effect to be assessed accurately and try to maintain the balance between the two, because these two groups are heterogeneous. There are heterogeneous groups. You are comparing two heterogeneous groups with different treatments and trying to see what is this treatment having an effect in these heterogeneous groups. So you remove a lot of confounder by doing propensity score and inverse probability therapy weightage. So this is a statistical tool which I think trainees have to have some clarity. So two groups you are comparing, looking at the outcome at different timelines. And because these two groups are heterogeneous, you try to remove the confounders by propensity score and try to create a balance between these two groups so that the treatment effect can be synthesized and crystallized, and you can attribute the effect mainly to the treatment intervention that is put in place. So that is the gist of this statistical tool. So here, so when they looked at this group of patients where antibiotic administration happened after 96 hours, so the time ratio was, they had faster occurrence of death, which was statistically significant. What it basically tells you in this study is, in all the patients where there was a delayed administration of cotrimoxazole for PJP after 96 hours, there was a faster occurrence of death, which was statistically significant. And they looked at patients who got steroids. So in this group, PJP, they looked at the group which got steroids, and even the patients who received steroids, there was a faster occurrence. FOD is faster occurrence of death, and that attained statistical significance. And the steroid dosage that they gave was around 75 milligram prednisolone in this group. But in this, the HIV patients, there were 29 HIV patients. Mostly steroids were given in HIV patients. Non-HIV also got, but only around 50% got in non-HIV. And 82.8% of HIV patients got steroids. But the caveat in this study is, the faster occurrence of death tended to happen more in HIV patients, but did not have in non-HIV patients, but did not happen in HIV patients. And they looked at 6 months mortality between steroids and no steroids group. There was no difference. But in the steroids group, there was a 2.48 times faster occurrence of death. Okay, so in the group that got steroids, there was faster occurrence of death. Although there was no difference in mortality, faster occurrence of death happened in the steroid group, more so in a non-HIV patient. So because in HIV patients, there was no faster occurrence of death. In non-HIV, there was a faster occurrence of death, which means to say this study is important because currently in ICU, what we are getting is non-HIV patients. And these are the patients where one should have a high index of suspicion to diagnose PCP and treat them, because otherwise they are going to die. Because these non-HIV patients, they're all immunocompromised due to solid organ tumors, hematological malignancy, autoimmune disorder. These were the patients who were already on steroids. So severe PJP in non-HIV patients, so 88%. So again, this study highlights in non-HIV patients, 88% did not receive any prophylaxis. So it just highlights that perhaps this is a group of patients which need to be put on prophylaxis to prevent this PJP pneumonia, is what that came out as a strong signal from this study. This study only told two things. Multi PCP basically said that delayed administration of antibiotics because low index of suspicion led to faster occurrence of death. And if you give steroids in non-HIV patients with PCG, faster occurrence of death happened. In HIV patients, there was no faster occurrence of death. So that was summarily that's the signal, that's the message that came. So for all our trainees, this is the study to look up to. So as we speak, this Cotrimoxazole study is happening where they're looking at efficacy of Cotrimoxazole as a de-escalation treatment in ventilatory-associated pneumonia. And this study has started in October 2023, and it is meant to finish in December 2026. So which means this drug is being revisited, re-looked at, and looked at as a very potent agent to look at as a de-escalatory antibiotics in this day and age. So it was about time that we revisit this drug and learn about it, and we start using it, because the sensitivity, as you see, from 1988 to 1997 has increased to 92%. And it's a good drug which has effectiveness against MRSA, gram-negative bacillus, protozoa, and PCP. And this is a drug one could possibly keep in mind, especially in immunocompromised patients, where you possibly want to cover PCP if you are evaluating, because this multi PCP study basically said that many of the non-HIV immunocompromised patients are coming to ICU with PCP, and if you are delaying antibiotic initiation, they are dying, and none of them are on prophylaxis. Only 12% of them are on prophylaxis. And if you give steroids steroids to these immunocompromised patients, that is causing faster occurrence of death, is what came out of this multi PCP study. So just to summarize, Cotrimoxazole has a good effectiveness against MRSA, actinomyces, listeria. Don't forget listeria, because this is a wretched bug which tends to cause meningitis in elderly patients. Gram-negative in ICU, Burkholderia pseudomulli causes milioidosis. Stenotrophomonas we see very often, and mycobacterium in immunocompromised, like mycobacterium avium intracellular, and so on and so forth. Protozoa toxoplasma we don't see very often in ICU, but it is a good drug of choice. And PCP we discussed elaborately, so it's a good drug of choice. So thank you, friends. So please request all of you to be a part of this academic celebration we are having in Bangalore from 18th to 20th October. So I invite you all to be a part of this academic celebration. So I request you all to submit your valuable work to Journal of Acute Care, which comes out every 3 months. You can visit my website. You can scan the QR code to access all my videos. So thank you. Thank you, Manila.